Hello, everyone. Thanks for joining. We're going to continue on our investigation series with some corneal imaging. So today we're going to look at topography and tomography. We'll spend most of the time talking about tomographies, and then we'll also touch on some anterior segment OCTs at the end, as well as some confocal microscopy. So with topography, if you think of it just being the top of the cornea, it's usually looking at your anterior surface curvature. Most kind of versions of topography will look at your central 3 mm. It's used in biometry, for example, with your IOL masters. And it's mainly indicated when you're looking at contact lens fitting, IOL calculations. And I'm going to have a separate video looking at biometry. So we're not going to go into this with much detail today. And I'll have another video that looks at biometry itself, how you choose your lenses, in the context of cataract surgery. Tomography is the main thing that most people will kind of consider when looking at corneal imaging. And tomography looks at the entire corneal surface, and it also gives posterior curvature as well as thickness maps. And the thing that you'll probably most come across will be something like a Pentacam or maybe an orb scan, which is a slightly older machine. And most of the time you're doing this to assess the corneal curvature, monitor things like a high astigmatism, look at ectasias like keratoconus, and also plan for sort of graft surgery and also monitor your patients post-graft to see how your graft is doing. So when you're approaching the Pentacam, it's, like I said, one of the most widely used tomography machines. So it's really worth understanding how to approach the refractive maps, especially because that's going to be the most useful to you, both in clinical practice and then if you're working up towards your oral exam or potentially the part 2 written, it's the Pentacam that will be used, or these sort of 4 refractive maps that will be used to assess you. And what we're going to look at first is essentially and how we're going to approach this in a sort of normal patient and what to consider when looking at this. So you'll get the 4 refractive maps, and here in the top left, you have the axial map that looks at your astigmatisms, and the warmer the color, the steeper that axial front curvature is. So for the greener, you've got sort of less steep, shallower parts of the cornea, and then the steeper parts of the cornea here in the yellow. Then you can look at corneal thickness. This is here in the bottom left. And again, the sort of warmer colors show a sort of thinner cornea. So if you sort of think about, your warmer colors are usually where things are kind of potentially going wrong, but obviously very kind of over here, very shallow corneas are also not a good thing. But the point is that the warmer colors along the corneal thickness map dictates a sort of thinner cornea. And as you can see in a normal eye, this cornea thins as it gets to the center. You then have the anterior and posterior elevations. So what this is basically showing is if you can imagine a best fit sphere put across that cornea on the front and also put across the cornea at the back. What the colors dictate is where the cornea is in relation to that sphere. So a warmer color is usually above the sphere, a thinner color is beneath the sphere. And when you're looking at ectasias, there are certain numbers that we look at that give us a higher risk that we're looking at something like keratoconus. So in a normal patient, we approach this, and these are the sort of findings that we'll see. So a nice sort of, with the rule, slight astigmatism, not really much in the realms of 2. The corneal thickness shows a thicker cornea on the periphery, thinning into the center, and then a nice anterior and posterior elevations with the numbers being not too high at all. So when it comes to interpreting the Pentacam, there's a few things that you need to do first. Obviously, checking the patient details first. There'll be somewhere here at the top where you're kind of looking at the name, the date of birth, checking that you're looking at the right patient. Consider which eye you're looking at. So OD for the right and obviously OS for the left. There's a nice sort of report on iGuru that is helpful for you to look at as well. If you want to sort of go across to their website, they have a nice report on how to interpret the Pentacams. So you're going to start off by checking the quality score. You want that to say okay. So that's here in this red line. That just tells you that your quality score is fine and you can interpret this well. And then you want to look at your K values. So your K values are going to interpret that central sort of central part of the cornea. You're going to look at K1 and K2 and then the astigmatism as well to see what the difference is. Km is just a mean value look between your K1 and K2s, and that gives you an understanding of what the astigmatism is. And then you're going to look at each map in turn. So you're then going to look at the actual full axial curvature. You're going to look at these lines. You're going to check these numbers and see whether or not these numbers fall outside of that expected range of about 42 to 47. You're going to look at your corneal thickness, see where everything thins. You're going to see whether or not there's any thinning that corresponds with a steepening. And then you'll also look at your elevation maps as well, like I said. So there are some common presentations that you're going to come across. So firstly, starting off with keratoconus, again, you're going to check your quality score and you're then going to look at your K values. Now, what's important to note here is these K values are taken from that central part of the cornea, and K1 is an average of K1 and K2 is going to be an average of K2, which is why these numbers aren't fully representative. So make sure you're looking at this map as well and not only looking at these numbers. And this map is a nice example as to why, because the 42 to 51 gives you that average of about 46. But that's obviously not what's going on, because you can see these numbers hitting 51 and even up to 53 in the inferior cornea and as low as 40 in the superior cornea. So this is obviously somebody that's got some inferior steepening of their cornea with these warmer colors that can be seen. We're then going to look at the thickness map. And again, with the thickness map, what you can see are these warmer colors showing a thinner cornea down to 430. And that corresponds with the area of inferior steepening that we can see on the axial curvature as well. And then the anterior elevation maps. So the anterior elevation is, again, we're looking at that best fit sphere, and you can see these warmer colors where it sits above it going up to plus 19, plus 20, and even up to plus 23. And then the the posterior elevation. And again, we've got numbers up to 35 and 37. And where this matters is if you're looking at the anterior elevation, and you've got numbers that are above 15, you're worried about something like keratoconus. And for the posterior elevation, it's slightly higher numbers at plus 20, which again gives you an understanding that you're potentially looking at keratoconus. So this is a typical pentacam that you'll come across with keratoconus, showing that inferior steepening corresponding with an inferior thinning and an anterior elevation maps that are giving you high numbers as well. And typically with keratoconus, your steepening and your thinning is just infratemporal, which is why, again, you can see in this left-sided eye, there's a slight temporal skew to that steepening. The next one you're most commonly going to come across is pellucid marginal degeneration. And the thing that you'll find in your SBAs, or if you're looking at it in an oral exam, is this crab claw configuration on the axial map, showing that inferior steepening again in a crab claw pattern. And again, we're going to go into more detail of these pathologies when we're actually going through our corneal tutorials instead. Then with astigmatism, so you've got different types of astigmatism. And again, these images are taken from the Eye Guru report, which is quite a nice way if you're first starting off to look at how things look. And the only reason I'm using these pictures really is just, there's a nice example here of what different types of astigmatism look like. So a regular astigmatism is essentially where the angle between your steep and your shallow axis and K1 and K2 is basically 90 degrees, and that you can see here with the with a nice 90-degree between your steep and your your with your steepest axis and your least steep axis. Irregular is where the angles between them are either more or less than 90 degrees. And these are patients that won't be really suitable for toric lenses when you're considering them for cataract surgery, because a toric lens relies on a regular astigmatism. And then the difference between with the rule and against the rule. So with the rule astigmatism, your steep axis is vertical, and then with against the rule, your steep axis is horizontal. And that's essentially all that means. And then finally, when we're looking at post-LASIK, what you'll find here is this is obviously a patient with a very sort of flat cornea with these sort of cooler colors, and then they've got here this inferior steepening because you've got these warmer colors here in the middle. And this essentially tells you that this is a patient who was probably quite hyperopic with quite a flat cornea, and then has had some laser to steepen that central cornea to correct their hyperopia. And you'll find opposite changes where you'll find a steep outer cornea with a flat central cornea for patients who've had myopic correction with LASIK. And that's an important thing to consider, because then there are corrections to be made to your biometry when listing these patients for cataract surgery later in their life. So moving on then to anterior segment OCT, this is a classic picture where you can see an OCT image that looks at your cornea, your angle, your iris, and even the anterior surface of your lens. And there's lots of uses. So within cornea, you're going to be using them to monitor things like corneal scars, understand the thickness of those scars, what layers they're affecting. You're going to use it for sort of post-graft assessment. But it's also quite useful in things like glaucoma, where you're actually also using the OCT to look at the angle. And again, when we start talking about closed angle glaucomas, we'll bring up the anterior segment OCT and what those things will look like along those tutorials as well. And then finally, with confocal microscopy, this is a very non-invasive imaging technique. It uses sort of diffuse light along the surface of the eye, looking at the cornea and the conjunctiva, and it uses sort of pinholes to essentially have a conjugate focus of a conjugate of focal points, which is where the confocal kind of comes from in terms of the term. And it has lots of uses, but it's mainly used to look at things like infectious keratitis, specifically looking at acanthamoeba. And you can refer to the tutorial of infectious keratitis, where I've kind of gone through the different types of microorganisms and acanthamoeba in general. And what you can see on this picture on this right is these very kind of bright points are looking at those acanthamoeba cysts, and this is the best way in terms of diagnosing acanthamoeba. And over the course of the treatment, these cysts will become less bright, they'll start to die off, and that's how you then try to progress towards getting a sterile cornea, especially if you're in preparation of a graft for any kind of acanthamoeba related scarring. You can also use confocal microscopy to look at things like dystrophies and degenerations, and again for post-surgical analysis for patients who've had previous grafts, but it's really mainly used in terms of the infectious keratitis and looking for these cysts. And you can help sort of in fungal keratitis as well, you can see different sort of findings too. So just to summarize then, like I've shown here today, there's lots of different imaging modalities for the cornea and the anterior segment, and you'll most commonly come across something like a pentacam. And you want a systematic approach to how to review these images, look at the quality scores, and actually go through things a bit more kind of systematically to then know what you're looking at on that scan. And then just consider using them whenever you have any diagnostic uncertainty with the patient. You'll use them, for example, if you're getting high K readings or a high astigmatism on a biometry, and you want to make sure that the patient has a regular or irregular astigmatism before planning for a toric lens, or in monitoring ectasias, for example, and keratoconus in the corneal clinics. So there's lots of different uses, and do consider using them in your own clinical practice, and especially if you're in your cornea clinics, then these are the sort of things you're going to come across most often, and I hope I've sort of kind of given you a way of approaching these different investigations, especially with the Pentacam, which can sometimes seem overwhelming in terms of the amount of information that you can get from it. But if you go through things systematically, especially with those 4 refractive maps, then you can sort of start to understand what it is that you're looking at with the cornea. So that brings us to the end. It's a quick sort of tour of corneal imaging. Use it as a reference, especially when it comes to sort of how to interpret a pentacam. And I'd really appreciate your feedback. It takes 2 minutes to just click that link at the bottom of the description of this video, and you can really help me out with that feedback. So thanks for joining, and we'll see you at the next one.